Good evening, ladies and gentlemen, and all those who are watching us online as well. I'm Miss Bhakti Khanolkar,
And I'm Ms. Ritika Marathe.
part of Mere Vitabiotics marketing team. On behalf of our organization, are pleased to welcome all the esteemed delegates to our discussion on India's big battle of Bulge. Further, we would like to express our heartiest greetings and deepest thanks to all those who have joined us in today's event.
To introduce us as an organization, Mere Vita Biotech is the group parent company of Vita Biotics, which is UK's #1 and world's fastest growing nutraceutical company. Dr. Kartar Singh Lalwani is the founder and chairman of Vita Biotics, which is headquartered in London. Dr. Lalwani is a bioscience inventor who has successfully commercialized his own inventions, creating a healthcare business that officially stands as Britain's fastest growing and #1 vitamin company. Mere Vita Biotech is a 4 times Queen's Award winner, which is the first and the only British nutraceutical company to receive Queen's Award for innovation in vitamin research. Mr. Rohit Shelatkar is the Vice President at Vita Biotics Limited. He is also a member of the Board of Directors in the international ventures of Vita Biotics in Egypt, South Africa, India, and Indonesia. Our Indian Board of Directors comprises of Ms. Uma Kalekar and Mr. Rajesh Taude, who have been two strong pillars of success of Mere Vita Biotics in India. Indeed, a successful organization is a reflection of great leadership, and Mere is fortunate to be led by such remarkable personalities.
Dear all, we want to bring to your attention a critical battle that India is currently facing, the battle of the bulge. Obesity, a global epidemic, has firmly established itself within our nation's borders, affecting millions of individuals across all age groups and socio-economic backgrounds. According to the National Family Health Survey conducted in 2015-16, the prevalence of obesity among adults aged 15 to 49 years in India was around 20.7%. The data also reveal the prevalence of obesity was higher among women, that is around 23% as compared to men, 7.8% in India. Childhood obesity is also a growing concern in India. A study published in the journal Pediatric Obesity in 2020 estimated the prevalence of obesity among children and adolescents in India to be around 19.3%. In the battle against obesity, a multifaceted approach is crucial for success. While lifestyle modifications and regular exercise form the foundation of healthy living, there are cases where additional interventions may be necessary. Among these interventions, the inclusion of orlistat can play a significant role. Orlistat, in combination with lifestyle modifications and exercise, can serve as a valuable tool to aid in weight management. By inhibiting the absorption of dietary fat, orlistat helps create a caloric deficit and promotes weight loss. It can be particularly beneficial for individuals who struggle with excessive fat absorption or have difficulty achieving their weight loss goals. Orlistat has been approved by both US FDA and EMA for obesity treatment. And in 2022, it has been approved by ESI, that is Endocrine Society of India, as first-line treatment for obesity. Owing to its efficacy and superiority over other molecules, it becomes the #1 choice for obesity management today. Mere is resolute in its commitment to foster transformative weight management journey through its exceptional brand, Reshape, which features orlistat. So let us begin our today's discussion starting with our director, Mr. Rohit Shelatkar, Vice President UK's. So can we have his live session, please?
Good afternoon. So, today we are going to speak on obesity, breaking the obesity cycle, unraveling the missing link. It's going to be very interesting. Worldwide prevalence of obesity has nearly tripled since 1975, mainly due to urbanization, which means less physical activity and more fast food. Age standardized prevalence of obesity has increased from 4.6% in 1980 to about 14% in 2019, which shows how fast obesity is growing around the world. Genetics can play an important role in obesity. The correlation between genetics and the environment, including nutrition and lifestyle, contributes to an individual's susceptibility to obesity. Epigenetics, which include gene expression changes, which can widely impact obesity risk, are being actually investigated now. The process of altering gene activity without modifying the nucleotide sequence is defined as epigenetics. It controls gene activity and the growth and development of the body. Epigenetics changes are often reversible because genes can be turned on or off by switches through environmental intervention. Obesity has become an epidemic with the fourth highest risk factor associated with disability adjusted life years. The prevalence of abdominal obesity in India was found to be 40% in women and 12% in men. The findings show that 5 to 6 of 10 women between the age of 30 to 49 are abdominally obese. Prevalence of generalized obesity as well as abdominal obesity were reported to be 20 and 23.7% respectively. Obesity rates have increased by about 25% in a decade. So, the last 10 years, the increase in obesity has been 25%. And if you see this table here, it shows the top 20 countries affected by obesity with a risk to public health and forecasted figures for up to 2030. Obesity is driven by modifiable lifestyle factors whose effects may be mediated by epigenetics, which means changes to the genetic structure. So we normally think that what we are is what we get from our parents in the form of a genetic code or a genome, and it cannot be changed. But that's not true. Actually, several environmental exposures and lifestyle factors can induce epigenetic aging accelerations, including obesity, thus leading to an increased risk of age-related diseases. And hence, uh, as you now know, that environmental factors can make us more susceptible to being obese. They also environmental factors and lifestyle changes that can reduce the chance of us being obese. A child with one obese parent has 3 times more risk of becoming obese than a child born to non-obese parents. And if both parents of the child are obese, then the child has tenfold more risk of future obesity. Now, that is the impact of genes and genetics on future generation obesity. But the good news is that by looking after yourself, but adopting a healthy lifestyle, you can actually alter epigenetics. You can alter the genetic code. You can make the genes work in favor of or against obesity. So here are some examples, and we're going to talk about the epigenome and the molecular structure first before we get into lifestyle changes. So epigenome has been described as the molecular bridge that connects gene regulation and environmental factors that define the risk of obesity. Epigenetics is a discipline that links environmental factors to patterns of genetic change, such as between rapid changes in dietary habits and the observed obesity phenotype. Epigenetic changes are reversible, making them appealing targets for therapeutic and corrective interventions. Epigenetic modifications can be thought of as a differential packaging of the DNA that either allows or silences the expression of certain genes across tissues. The main epigenetic mechanisms include DNA methylation, a histone modification, and microRNA mediated regulation. So, DNA methylation as a key of epigenetics may be the mechanism linking obesity and clinical manifestations. Genetic modification through lifestyle changes can also influence hormone balance. Example, the balance between leptin and ghrelin. Leptin is a satiety hormone, and ghrelin is a hunger hormone. Leptin deficiency can cause diet induced obesity and metabolic dysregulation. About 50% of females with polymorphism came up with binge eating. The MC4R polymorphism influences the release of ghrelin, which means more hunger. And if you see the figures here, it clearly shows the first one shows you the peripheral appetite stimulating hormone ghrelin, the hunger hormone, and the satiety hormone leptin both feed back to the brain to influence the appetite and hunger. So leptin goes up, your satiety, you get a feeling of satiety and you feel less hunger, but the ghrelin goes up, gives a message to the brain, makes you feel hungry, and you eat more. So when you are having an adequate sleep and an energy balanced diet, levels of ghrelin peak near the beginning of the sleep and decrease across the sleep episode, as you see in the first part, the part A, the graph of ghrelin. That implies you don't feel hungry during night hours as long as you're asleep. Thus, from a circadian perspective, levels of ghrelin increase across the day and decrease across the night under healthy conditions. What are healthy conditions? Assuming you're sleeping at night. In similar conditions, levels of leptin are higher during sleep, which means you are satiated, you don't feel hungry when you're sleeping, than during wakefulness. Peak near the beginning of the sleep and decrease thereafter, as you can see on this graph C there. Now, insufficient sleep and circadian misalignment predispose individuals to poor metabolic health and promote weight gain. When sleep is restricted but diet is controlled, the appetite stimulating hormone ghrelin is increased and satiety hormone leptin is decreased, resulting in increased hunger levels. And that's why you see that when you don't sleep at night, you often get engaged in binge eating. Now, this slide here is very interesting. You can see environmental factors like excess food, less exercise can lead to higher BMI and being overweight, and that leads to accumulation of adipocytes, the fat cells, and hypertrophy of that, the fat cells accumulation, can lead to pro-inflammatory diseases like type 2 diabetes, hypertension, cardiovascular diseases, non-alcoholic fatty liver, and different kinds of cancers. Epigenetic biomarkers are able to represent the effect exerted by environment and a certain lifestyle on the metabolism of an individual. Several epigenetic alterations can be used to distinguish responders from non responders or help design a unique weight loss strategy for an individual in a clinic by a dietitian or by a doctor. Identifying methylation differences in certain genes can be used as prognostic biomarkers for obesity. TNF has lately gained attention as a possible biomarker. Weight loss responders to a hypocaloric diet had a reduced methylation of TNF and leptin genes in adipose tissues. So, this is a clear biomarker. Similarly, DNA methylation of appetite regulating genes POMC or NPY could serve as a biomarker of weight loss maintenance versus weight regain. Lower POMC methylation levels in blood were connected to weight loss maintenance, but lower NPY methylation predicted weight rebound in 32 weeks after a diet based on weight loss intervention. Beta 3 adrenoreceptor gene presents high methylation levels in white adipose tissue and it contributes to susceptibility to obesity. In obesity, there are several circulating genes like MIR3659 that may act as possible biomarkers of dyslipidemia. And there are many genes that interfere with the decrease in food intake, restore weight gain, and enhance energy expenditure, glucose tolerance, and insulin sensitivity. So, identifying these early biomarkers and understanding the underlying epigenetic changes can provide direction for early intervention in not just adult obesity, but also in childhood obesity. And this diagram here clearly shows you how environmental factors like unhealthy eating habits, sedentary lifestyle, sleep disorders, etc., can have a negative effect on DNA methylation, histone modification, and non-coding RNAs. Whereas good lifestyle like healthy environment, healthy nutrition, physical activity, good sleep can have a positive impact on these biomarkers. Evidence There is a lot of evidence that directs us to the use of micronutrients to modify our genome or to work on epigenetics. Deficiency levels of antioxidants like vitamin C, vitamin D, vitamin E, beta carotene may alter the genetic expression of leptin, leading to development of leptin resistance. Obese children have vitamin D deficiencies resulting from vitamin D sequestration in adipose tissue, and consequently its reduced bioavailability. Obese adults have low levels of B1, B6, B12, and folic acid. Higher B vitamin levels may improve body fat level, because B vitamins are also responsible for producing energy from the food that you take in. Zinc deficiency increases oxidative stress and inflammatory response in obese individuals. Obese patients present higher requirements of zinc, magnesium, chromium, manganese, etc., which clearly shows the involvement of these micronutrients in carbohydrate and fat metabolism. And that's why it's very important to understand that these micronutrients that are not found in the right quantities in our food have to be supplemented. And that's why right supplementation with vitamins, minerals, and some natural polyphenols, bioactive elements can actually trigger epigenetics and can have a good balance between leptin and ghrelin, and can influence the genes or biomarkers of epigenetics in the treatment of long-term obesity. So, what is an epigenetic diet? I mean, this slide gives you all the information and what you should eat and what you should not. But in short, epigenetic diet refers to bioactive nutritional compounds that can induce epigenetic changes and alter gene expression. This ever expanding list of epigenetic nutrients include, of course, vitamins, minerals, polyphenols, and various phytochemicals. Among these phytochemicals are resveratrol. Resveratrol comes from grapes, tea catechins and polyphenols that come from green tea, and genistein, quercetin that come from soya, curcumin that comes from turmeric. Turmeric is very commonly used in food. Sulforaphane that comes from cruciferous vegetables like cabbage, cauliflower, broccoli, etc. And then, of course, diallyl disulfide that comes from spices like garlic. This would be an epigenetic diet. And how could you further simplify this diet is by looking at this food plate. A half of what you consume at a time, about 50% of the plate, should be your fiber source, your fruits and vegetables. Well, you don't have fruits exactly at the time when you eat, but it would be more like vegetables on a food plate. A quarter of your plate should be low glycemic index, complex carbohydrates, which could be rice and whole meal cereals, etc. And the one quarter should be a healthy source of protein, ideally white meat, eggs, or fish. Fish also gives you omega-3 fatty acids that are anti-inflammatory and strong antioxidants, and also important for epigenetic gene expression. Exercise. Exercise-induced changes in adipose tissue, DNAM, may affect cellular metabolism. Tissue-specific epigenetic alterations in different tissues are associated with obesity. Exercise-induced changes in adipose tissue may affect cellular metabolism. Exercise can reverse the morbidities by triggering epigenetic modification. Reductions were observed in DNA methylation in regulatory region of the PGC1 alpha gene, which regulates energy expenditure and mitochondrial biogenesis. A single bout of acute exercise, 10 minutes in total, 70 to 90% of maximum heart rate, say not too rigorous, increase several members of the MIR 378 family, known to regulate the PGC1B gene, resulting in improvement in mitochondrial function, fatty acid oxidation, and insulin sensitivity. So you can see how a short bout of 10 minutes of exercise can also have its effect on gene regulation and gene expression that regulates fat metabolism and energy metabolism and insulin sensitivity in the body. So acute exercise training has also been shown to be associated with decreased DNA methylation and promoters of certain genes that play essential roles in mitochondrial activity, insulin sensitivity, and energy expenditure. Sleep. There is a close relationship between epigenetic alteration and total sleep deprivation. And that is affected again at gene level, which causes fatty acid synthesis and fatty acid utilization and metabolism. The circadian rhythm, what we call, is a translational, transcriptional feedback loop composed of positive transcriptional regulators. A single night of sleep deprivation was found to increase DNA methylation in promoter of the tryptic 1 gene and enhancer of the region of the PER1 gene in healthy main adipose tissues with elevated blood cortisol levels, that is a stress hormone, and impaired glucose balance. So you can see how sleep can affect DNA methylation in an alter gene expression that has direct effect on stress hormones. And more stress hormone, there is more cortisol in the brain and in your blood. There'll be less serotonin, so there is less feel good hormone, and that affects directly your glucose metabolism. So lack of sleep has also been demonstrated to increase the expression of certain genes that result in decreased histone acetylation, and hence sleep becomes very, very important, and that confirms the role of sleep deprivation in the development of obesity, most likely via disrupting the circadian clock genes. um, so, talking about different ways of controlling obesity, there are drugs that are in the market that that doctors prescribe, that are given to patients by their healthcare providers. One of the drug that has shown a good result in clinical trials is Orlistat. Although patient compliance with Orlistat is not as much as it should be, but it does exert its therapeutic activity on the lumen of the stomach and the small intestine by forming a covalent bond with the serine residue site of gastric and pancreatic lipases. The inactive enzymes are thus unavailable to hydrolyze dietary fat in the form of triglycerides into an absorbable free fatty acids, and monoglycerides therefore prevents the absorption of dietary fat. So in short, it's a fat binder, and it would throw the fat out of the body, doesn't get absorbed. So that's how orlistat works. But then there are also natural ways of treating obesity, and a few ingredients have gained popularity in the recent past. One is capsaicin, that comes from capsicum, bell peppers, and green and red peppers. So capsaicin contributes to thermogenesis, which increases energy expenditure by the maintenance of body weight and prevents development of obesity. A second ingredient could be coffee bean extract containing chlorogenic acid that reduces fat absorption from diet, thus reducing fat stored in the liver and improves the function of the fat burning hormone adipopectin. Hydroxy citric acid is the third one I can think of, and hydroxy citric acid present in different forms. They come in tablets, capsules, liquid forms as well. It stops the conversion of sugar into fat, in turn converting into energy. So the increased energy causes corresponding increase in serotonin production, which could potentially suppress appetite to help you stay fuller longer. And then finally, I could think of catechins coming from green tea that lead to decrease in adipocyte differentiation and proliferation, and decrease the expression of genes involved in lipogenesis, increase of adiponectin levels, decrease leptin, and prevent obesity and weight gain. There are some futuristic approaches that the industry is looking at. There are some ingredients that are still not fully understood or still not fully explored, but there's a lot of science and a lot of clinical trials coming up around the world on some new ingredients. So for example, turmeric polyphenol inhibits adipogenesis of by increasing the fatty acid oxidation and suppressing lipogenic and inflammatory gene expression. Then there is opuntia extract that reduces liver fat and blood level in insulin, and and it promotes phosphorylation and activation of protein kinase B, which suggests involvement in insulin and AKT dependent signaling pathways in mediating plant action on fat accumulations. A very promising ingredient, opuntia. And then brown seaweed extract is known to decrease LDL, low density cholesterol. Okra, which is also called lady's fingers, it's a very commonly used vegetable, particularly in India, has potential of upregulating thermogenesis. Naringin, modulates multiple pathways involved in the onset and progression of obesity and comorbidities. Then there is hesperidin that regulates lipid metabolism. There is carob that decreases free fatty acid released from the adipocytes, and proanthocyanidins, which could improve blood lipid indexes, regulate glucolipid metabolism, and affect the expression levels of lipid metabolism related to cytokines and their mRNA in obese patients. However, a lot of these studies are done in vitro. That is, a lot of these studies are done in animal. There is still not enough data on humans, but there is a lot of data on a few ingredients like turmeric and hesperidin. There's a lot of data on that. So the future looks bright with a lot of natural intervention, and hence we have a drug solution, a pharmaceutical solution in the form of reshape orlistat, and also the natural intervention in the form of reshape natural. And of course, we're looking at the futuristic, in the approach in nutraceutical and polyphenol and antioxidant therapy for weight loss and help obese patients. So that's why there is reshape natural. So finally, the take-home message from this short presentation is that obesity is a complex multifactorial disease characterized by an intricate interplay of numerous pathways linked to inflammation, metabolism, oxidative stress, hypoxia, and others. Therefore, there is still much to learn before we entirely comprehend the epigenome's role in obesity, but there is definitely a role of epigenome. The epigenome can be altered by the effect of external environmental factors like lifestyle, nutrient intake, physical activity, stress exposure to toxins, medical history, etc., allowing the body to provide a dynamic response in a short period of time. Eventually, modifiable nature of the epigenome may aid in anticipating an individual's obesity risk at an early stage, opening the doors to implementing customized obesity prevention treatments. Nutrition and lifestyle do have a very big role to play in epigenetics and the treatments of obesity. So while we talk about obesity and the underlying problems and the effects obesity has on lifestyle diseases or non-communicable diseases, the good news is that both through pharmaceutical intervention and through natural intervention, we can actually have an epigenetic approach in changing the genome, altering the gene expression, and thus helping carbohydrate and fat metabolism and helping the obese patients in long term. Thank you very much.
Thank you, Mr. Rohit. He indeed highlighted the prevalence of genetic obesity and the ways to combat it. So, moving on to the second speaker of tonight, let me welcome Dr. Sanjay Borude, Bariatrics Consultant, Jaslok Hospital. He is one of the pioneering surgeons in obesity surgery in India. He is the holder of Limca Book of Records for bariatric surgery on 11 months old baby. He is currently Professor Emeritus at LTM Medical College, Mumbai, and consultant at top hospitals in Mumbai and Pune. Dr. Borude is a seasoned expert in the management of complex obesity cases with a profound specialization in bariatric surgery, reflecting extensive experience in successfully guiding patients through transformative weight loss journeys with a focus on comprehensive care and long-term outcomes. Generation Excel, Tackling and Preventing Childhood Obesity in India, written by Dr. Sanjay Borude, offers profound insights into the urgent issue of childhood obesity, highlighting the need for comprehensive action and fostering a healthier future for our children. It serves as a compelling call to address the epidemic through informed choices, supportive environments, and collective efforts. We eagerly anticipate to listen to Dr. Sanjay Borude's session on combating obesity at all ages, specifically adult obesity. I welcome Dr. Sanjay on the dais, please.
Good evening, friends. Uh, I take this opportunity to introduce the today's uh, main disease, which we call this as a mother of most of the diseases. Obesity leads to many metabolic issues, and that leads to early morbidity and early mortality also. So that is the primary reason that one should look for obesity and begin the treatment of obesity as soon as possible. I take this opportunity to share my experience, whatever happened in the last 23 years of my exclusive bariatric practice. I take you around along with me the what is obesity and how to deal with it. I congratulate Mr. Rohit Shelatkar for introducing that new concept. Even I believe in this concept, that is epigenetics of obesity. It's very, very important, which is unknown to lot of us. We are here all gathered today, the real good bright minds of our society, and we need to take it ahead. We are the people who are going to inform all our patients and what is normal nutrition and what is epigenetic nutrition. It's very important in today's world. So what is obesity? Obesity is an excess of just accumulation of adipose tissue, that is fat. And because this causes lot of metabolic disorders, so WHO has taken cognizance of this, and in 2015 WHO has recognized this as a non-communicable disease. I'm going to simplify and talk in very simple words today. What are the types of obesity? Endogenous and exogenous. Endogenous within the body, and exogenous, which is working from the outside sources. Endogenous causes are genetic, familial or hormonal, and exogenous, as you know, they are lifestyle problems. There are two types of people. Whatever these causes would be, there are certain people who are insulin sensitive and certain people who are insulin resistant. You must have seen very commonly a obese patient always complains about, doc, I eat less than you. Doc, I eat less than my friends. My friends, they hog, but they never put on weight. I open my mouth, I drink water, and I start putting on weight. Everybody must have heard this by an obese person. That is where that condition lies. That is insulin sensitivity. The insulin sensitivity is that it's a good metabolism. Whatever they would consume, the number of calories, but the equal number or more number of calories they automatically burn. So even if they have carbohydrates, especially the natural carbohydrates, today it's a season for mangoes. Everybody love mango. Mango comes with lot of calories. Now this particular season I am bombarded with all this question, doc, can I have mango? How many mangoes a day? So this is a very common question because mango has naturally occurring carbohydrate calories. But people, those who are insulin sensitive, they can definitely burn those calories. So they are allowed to have those naturally occurring carbohydrates. But no matter, even if you are insulin sensitive, but refined carbohydrates, which comes in package forms, they are always big no, 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 no. That one thing that one must be sure about it. Insulin resistant people, those are the ones which are unlucky ones. They have small amount of calories, but all those calories are being synthesized in their body. They are converted, the glucose converted into fat. And that's their issue, that's their bad luck. So how a normal person becomes obese? Say everybody has, say morning till evening, we need some calories. Let's consider that we need about 1000 kilocalories, but with every meal if you have 1500 calories. Now this extra 500 calories, if you don't burn them out, they have to settle out in your own body. So where do they go and settle? In your fat cells only. So this is very common. Please understand the small video about what is a normal anatomy. This is a food pipe, stomach, the small intestine and the large intestine. Food that is consumed gets dropped into the stomach, remains here for 2-3 hours, gets properly mixed with acid, enzymes, and then go further here for the absorption. Now this absorption, maximum absorption takes place in first 100 centimeters of the jejunum. So this later that it starts reducing the quantity. Now if you have seen small children, 3 months old baby just on mother's milk, 6 months old baby on a puree diet. Later on, as the age advances, the child's intake starts increasing, and then you see that stomach which is innervated from all the sides, and that sends message to your baby's brain that don't have more. So baby starts saying no to food. If the mother overfeeds baby, we see baby vomiting it out after some time. So we have the stomach capacity limited, and that beyond that, if you start dumping food, then the volume of the stomach starts growing up. And then when you are told to go on a diet program, that is small volume the diet program. So here when you see the holes of the stomach is not filled in, so the message doesn't reach brain to the satiety center that you have had a food or no. So that is a primary reason for a diet to fail. This is a very important and common slide. You must know, a lot of people come and say, doc, I just had one small burger and that was my lunch or dinner, but you have already taken 550 calories. Doc, earlier on I used to have a full pizza, but now I've just had that small quarter, but still you have got 470 calories. Likewise, the fries, 480 calories. A small ice cream cone, that also 670 calories. But whatever with this small amount, the calorie dense food, but when you start burning, you see the 1 hour of exercise will let you burn only few hundred calories at all. Extreme exercise for an hour like hiking, aerobics, bicycling, tennis, they also allow you to shed less than 500 calories if you continue to do it for 1 hour. So mind you, whenever you take food, that what kind of a quality that you are taking. So we are practicing doctors. So we should know how to have a clinical setup, how to understand clinically a person walking in your office. Then when you start seeing the person walking through the door until he settles down in the counseling chair. So you study that, and then the patient comes and tells you, doc, am I obese? So how will you answer? So to understand, this is a very again common question. Whenever I go and partying outside, people come, yeah, you do this bariatric surgery, you are an obesity consultant. Tell me, am I obese? And I have to lose weight. What do I do? These are common questions to all of us whenever we go out or socialize. So these are certain updates as latest as 2019, which are done on the total number of publications on bariatric surgery, especially RCTs, meta-analysis and reviews. Now understand, this stage 0 is overweight but no complications. Stage 1 is overweight but one mild complication. And the third, stage 2 is overweight but one with severe complication like uncontrolled diabetes, uncontrolled high blood pressure and all. There is one more, which is ABCD, which is adipose-based chronic disease. There is third one and there are fourth ones also. Generally speaking, we grade obesity by body composition analysis and not just by weight, because whenever we stand up on a weighing scale, we out of the whatever weight that we notice, it is formed by four things. One is muscles, bones, fat, and the water. So that aggregation of this, that comes with this on the weighing scale. Now body composition analysis gives the difference. What is the percentage of muscles, bones, fat, or the water. Second is waist and hip ratio, and the third one, which is commonly attributed, which is body mass index. Body mass index is a small machine where the body composition analyzer, and it gives a report like this about your two types of fats. One is subcutaneous fat below the skin, which is non-metabolic, while there is fat which is inside the abdomen, around the organs. Like fat with liver gives you fatty liver and liver problems. Fat with pancreas give you diabetes. Fat with kidneys give you high blood pressure, and so on. So here we have now this is again by earliest was 2017. Now until today, BMI is still used to classify overweight and obesity. But now we consider body composition analysis, which is the most important to analyze anyone's obesity. This is a waist and hip ratio. You have to see that where you put your tapes. Waist circumference more than 40 inches in men and more than 35 inches in women, which is beyond this, which is bad. Then body mass index, this is a simple formula, weight upon height in square meters. Now there is international as well as Asia Pacific. We are short statured people, so our Asia Pacific guidelines, we have changed it about 10 years back. Earlier on, this was followed totally with the international. Now Asia Pacific is 22.5 to 27.5 is overweight, 27.5 to 32.5 is obesity grade 1, then it's grade 2, and more than 37.5 without any metabolic issue is considered morbid obesity, while 32.5 and with any one single comorbid condition will be considered as morbid obesity. As I said, obesity is the mother of most of the diseases. Obesity leads to diabetes, high blood pressure, stroke, heart diseases, and joint problems, weight-bearing joint problems, and many more cancers also. Hypertension, I'll just quickly go in this. Hypertension is caused by leptin, free fatty acids, insulin, which they stimulate the sympathetic activity and cause vasoconstriction. This is the commonest thing. And insulin resistance, and they cause endothelial dysfunction. That is another way of making this vasoconstriction effect, and that's how people develop high blood pressure. Sleep apnea. Now, obesity is one of the most important factors for the development of obstructive sleep apnea. It is more dangerous than high blood pressure or a diabetic status of that patient, because these patients, they remain sick most of the daytime, and then that's how the circadian rhythm which goes for a toss. When they go to sleep, the muscles of the body, including the throat, relax, and surrounding weight of the soft tissue partially or completely collapses to the upper airway. That is what you see here. And once after any weight loss method or after bariatric surgery, that surrounding tissue fat that is released, and then this is how the airway becomes open. And that's how after bariatric surgery, within a week to 1 month's time, patients on C or BiPAP, they stop their machines, they stop snoring, and that's the advantage, and that's how the metabolic issues also they start releasing. PCOD, it's a very, very common thing about 50% of the women are suffering from polycystic ovarian diseases, and this also caused because of hyperinsulinemia, and that which is leads to hyperandrogenism. And this is what that all these PCOD patients, they have all these endocrinological side effects, hirsutism, they have infertility, and so on. Diabetes mellitus type 2, especially as I said, this is caused specially by these cytokines, which are generally these are the ones which cause these are the pro-inflammatory hormones which leads to their metabolic issues. Now there is another etiology of by the American Diabetic Association, which is type 1 diabetes. It is purely because of the beta cell destruction. Type 2 diabetes is either insulin resistance or without the secretory effect. Third is genetic defects of beta cell function, genetic defects of insulin action. This is I am talking about along with obesity. And the last one, which is the gestational diabetes mellitus, pregnancy induced diabetes. Normally what we see is there are alpha and beta cells. The beta cells give out this insulin, while the alpha cells give out glucagon, and the treatment is done by the gut hormones, which is important. Now this gut hormone, which is primary gut hormone, is a GLP-1, that is glucagon like peptide 1, which is a gut derived insulin agonist, and this suppresses the glucagon secretion by alpha cells of pancreas and stimulates the insulin secretion by the beta cells of pancreas. This also delays the gastric emptying and causes early satiety. Now there are lot of studies which I have done. Another study by the PET scan, so that they are also shown, because there are insulin, that's abdominal obesity, insulin stimulated glucose uptake rate markedly reduced in skeletal muscle. This is more of theoretical. I'll go ahead. So I was talking about the inflammatory response by abdominal fat, the visceral fat, which is which releases hormones, that pro-inflammatory hormones, which are called cytokines, and then they cause insulin resistance, and this is a hallmark of type 2 diabetes. They push a normoglycemic person to pre-diabetic status and then to type 2 diabetes. There is disruption of the fat metabolism also. There are a lot of things which the obesity comes with, and this is very funny, that altered metabolism that causes fat molecules into the blood and reduced insulin sensitivity. Again, reduced insulin sensitivity means rise in insulin resistance. Again, that leads to diabetes. Now, how does this surgical results they affect? There are a lot of randomized controlled trials which have been done that they show metabolic surgery, particularly gastric bypass. I'm going to talk about this later. Results in complete remission or improvement of diabetes within 2 years for more than 90% of the patient. In some cases, at the time of hospital discharge, even before the significant weight loss has started. Now this was the one reason that we started doing patients with diabetes but non-obese, because gastric bypass surgery that works not by weight loss but straight by the hormonal changes. So when we already have been seeing in obese patients, why not give it a chance to non-obese people who are uncontrolled diabetes? There were some lot of head-to-head studies also have shown metabolic surgery has a role to play. Global clinical guidelines have changed, and now they recommend this surgery at the beginning when you contract the diabetes. This was another paper, the mechanism in bariatric surgery with the gut hormones, and this was also latest as to 2018, and they also talk about GLP-1 and peptide YY. There are again a few more studies which were as latest as 2018 by American Diabetes Association and SAGES. So they also have recommended metabolic surgery. Now here, metabolic surgery versus medical therapy. It's a controversial subject, but now it has been proved without doubt with all the latest work, with all the study trials, that metabolic surgery overplays this medical therapy. But may I tell you here, whatever I am talking about surgeries, they are for the morbid obesity only. I am not talking about the mild and the moderate obesity. So there are another few studies which show that 2021 study, bariatric surgery lowers A1C in real world clinical care. Improvement are sustained for at least 6 years. Benefits were greatest for younger people and those with shorter diabetes. Therefore, efficacy results from RCTs are generalizable to routine clinical practice. One more thing I would like to tell you here. A lot of patients, when they are diagnosed as diabetics, they wait. They go to their doctors. Doctors also start with anti-diabetic therapy for lifestyle changes. They go ahead. But again, once diabetic, always a diabetes. So that is how they keep changing their drugs, keep adding their drugs, and then at the end of the end of few years, probably they are switched on to insulin. In my last 20 years of practice, what I have seen, there are two types of diabetes. Certain diabetic patients are very fast giving into complications, while certain are they can live for 40, 50 years. You will see a lot of patients who would tell you, Doc, I am diabetic since 20 years, 30 years, 40 years. They do not have any complication. But there are certain diabetic patients that we have seen, they show progress in the complication as soon as they have contracted diabetes. They start getting, neurovascular complications. They start getting gangrenes of the end vessel diseases and the organs, and that is how they suffer a lot. You, as a clinician, I request everyone to pick up these two different diabetics and start the treatment very aggressively as soon as you start noticing that this diabetic patient is progressing very fast towards the complications. ASMBS is the American Society of Metabolic and Bariatric Surgery. That's 2021. They have the position statement here. Again, that recommends that as you pick up diabetes, start giving the aggressive treatment. Please do not wait. Now, they come with this metabolic syndrome. And what is metabolic syndrome is this: waist circumference more than 40 inches, triglycerides more than 150, HDL less than 40, blood pressure more than 130/85, and fasting glucose more than 110. Any two or three of these with little higher BMI will lead to metabolic syndrome. Now we have changed to now expanded metabolic syndrome with OSA, that is obstructive sleep apnea, type 2 diabetes, NASH, dyslipidemia, PCOS, and high blood pressure. So the best treatment, everyone knows, go globally, go anywhere in the world, diet and exercise is the best treatment. But again, be smart through whether it's a weight loss diet or a weight maintenance diet. Most of the people, they start with, I have stopped taking rice, I have switched over to vegetarian or vegan diet. And these are the commonest ways that patients did surrender to different types of methods. There are certain OTC products which are easily available in most of the chemist shop, and people get prey to those, and then they start getting problems even. So understand this: the reality of fitness is 20% exercise but 80% nutrition. just on the basis of this, one should start losing weight. And how to lose weight and what is a standard? The golden rule is weight loss through a diet is cutting down the caloric intake by 350 to 500 calories kilocalorie per day, and to enable a weight loss of 0.7 to 1 kilogram per week, and not a crash. Don't switch on to a crash diet program and start losing about 500 grams every day. The weight loss differs from individual to individual depending on age, body type, initial weight, activity level, compliance and all. Most of us are sedentary people. Those who have about a lot of bodily work, they do not, their diet pattern and sedentary workers' diet pattern is two different things. The process of weight loss must be slow and gradual to be consistent. Now again with the diet, how to choose a right diet, how to maintain the quality of the diet, how to avoid the side effects by diet, how to taper the diet, for how long continue the diet, and when to stop the diet program. For this, do not go to any other person than a good nutritionist, and with that's a qualified nutritionist, and take a diet that has no expiry date. Once you are on a diet, you have to continue the diet program for all your life. There is no expiry date for that. Similarly, the exercises, a lot of people call, especially in metros, why the obesity is rampant here is because of people don't go and exercise also. Everybody is busy. Everybody has to take up mode of transport by any which ways. And that is the reason. People don't want to walk. People don't want to take up to any small, easy exercise program. That indoor exercises program, even I also got this hooked onto this program because of lockdown. So everybody had this problem. Most of my patients, post-bariatric patients, even those who are just contemplating surgery, those who are on a borderline, moderate obesity, they have gone to morbid obesity just because of lockdown. So, but there are certain indoor exercises without any gadgets. You don't have to use any, the weights and everything. So you can start up with warm-up exercises, stretching exercises, cardio and yoga. These are stretching exercises one can see, and they can be easily done without any gadgets at home. Surya Namaskar I recommend to everyone, which is the best all-round exercise which the globally everybody follows. The yoga, another one which I recommend, which is yoga. Now benefits of exercise. The short duration exercise benefits are smaller, but when you do a chronic exercise program, so the results are sustained. You start doing exercise and you just stop it within a few days or months, the exercise, all the results, they start waning off. But continuous exercise will definitely give you good results. Now bariatric surgery, people understand now bariatric surgery has come in vogue since past 8-10 years now. But bariatric surgery has lot of big history. The first bariatric surgery actually was done in 1950 in University of Minnesota, and it was a jejunal bypass, something like our Roux-en-Y gastric bypass, which we do now. This Roux-en-Y gastric bypass, which we do today also, but the first surgery was done in 1960, and it was an accidental outcome in a patient with one who met with a road traffic accident. So what are the criteria for bariatric surgery? It is for Asia Pacific standards, it is BMI more than 37.5 without a comorbidity, or BMI more than 32.5 with comorbidity. BMI more than 27.5 as a second line therapy for failure of optimum medical management. This is very important. Optimum medical management, which we offer to those people, those who are aggressive diabetics and or established secondary complications by type 2 diabetes. Motivated and committed to lose weight. This is very important. We can't force surgeries those who are not motivated. Failed on conservative method of weight loss. Age between 18 to 65, but this is again important. Age less than 18 years or more than 65 years in the presence of severe obesity related comorbidities or disabilities. Though I have operated a small infant, 11 months old baby, because they had leptin issues in that family. The parents were, babies were born out of consanguineous marriage of the parents, brothers, sisters, and the family had lost their first baby at the age of 1.5 years with the weight of 22 kilos, purely because of obesity and breathing disorders. This second baby, which came to me when she was 11 months old, and later on she started at showing as like a previous baby, and this baby also we would have lost. So I had taken that decision, operated her in Rich Candy Hospital. Now today I'm proud to say she's 13 years old and she's living normal life with normal milestones. So this surgery has proved as a life-saving procedure in that particular baby. I have recently operated her younger brother who was 2 years old, 20 kilos. Again the same genetic deformity. They have LEPR, that is leptin resistance. They have leptin, but the receptor which is missing. So the leptin doesn't work. So many times when we contribute the causes for obesity as leptin, but this baby has something different. Now there are certain papers where we can operate patients who over the age of 60 or 65, and this was the latest one, 2021. Bariatric surgery is increasingly performed in elderly patients. Elderly versus younger patients have higher disease burden and adverse outcomes. Because these are a higher age, so they may have different comorbidities also. So giving a solution with bariatric surgery is very important. Mortality is threefold higher in elderly patients and age greater to or equal to 65 years. Mortality and morbidity were significantly less for sleeve gastrectomy than the gastric bypass. So sleeve gastrectomy, we still consider this as a step 1 procedure, and then the gastric bypass, which is a step 2 procedure. Contraindications for bariatric surgery are patient who is unable to participate in prolonged medical follow-up, non-stabilized psychotic disorders, severe depression, personality and eating disorders is another contraindication. We do not expect good results post-bariatric. Alcohol abuse or the drug dependency, diseases threatening to life in short-term period, and pregnancy. These are 5 contraindications where we defer bariatric surgery in those patients. Here, bariatric surgery evolved in India by 1999. We started doing these surgeries in year 2000. We started off with this particular surgery, which we used to do open surgeries, and we used to bear the problems because they always come with big fat bulge on the abdominal wall. So opening and doing these surgeries on those patients used to be a nightmare. These patients would, the wounds won't heal for 2-3 months time. Then later on, then the gastric bands have come, and we've still moved from the gastric bands. I am not showcasing or any of these surgeries right now. I wish to announce, with the permission of Mayor, that we are coming out with on the 8th of July, we are coming with a live surgery session which who are interested, who can join us for this live surgery session. It will be online as well as it's going to be showcased from Critical Hospital. So everybody can take that advantage, and we're going to talk about live surgeries and different procedures in one that live surgery. The commonest surgery today is done, which is a sleeve gastrectomy, making stomach size small. So here, what you see here is this is a big stomach. Now what we do is we make the stomach size small. As our nails which grow, we clip the nails. Hair that grow, we cut hair. So similarly, which we don't allow them to grow much. So this stomach which is overgrown, which we cut it off, and we remove this part of this stomach, which is excess, which is useless for our body. The upper part of the stomach is called as fundus. This is the body of the stomach, and this is the antrum of the stomach. This upper part of the stomach, which is called as fundus, this secretes hormone called ghrelin. Mr. Rohit was talking about this ghrelin, leptin, all these the hormones which I would like to show you. This is produced mostly from this area. When we do this bariatric surgery, you see most of the fundus we take it out of body. So no more ghrelin. So only the little part of the fundus that we leave behind for the minimum appetite. So the advantage of this bariatric surgery is basically the the appetite goes down, and volume to consume food that goes down, and that complies to each other, and that is how they feel they feel satiated quickly. Now this is Roux-en-Y gastric bypass. So here we cut off here upper part of the stomach pouch, make a small pouch here. Now as I was saying, normally the food comes here, remains here for 2-3 hours, get properly mixed with acid and enzymes, then goes here for absorption. Maximum absorption takes place in first 100 centimeters. So we do not want the food to come to this area. So we bypass. So we cut off this intestine here and bring this loop up and join it here. Now the food that comes here stays here. This wall is stimulated. This sends message to the brain that you're full, don't have more. So the patient stops eating with the full stomach capacity. Then this food bypasses the whole of this and goes out and out. And because this is retained in the body, so this is whatever secretions, stomach secretions, duodenal secretion, bile secretion, pancreatic secretion, they come and meet this food out, and then whatever remains, these are all tailor-made surgeries. So when the patient comes to whatever ideal body weight, then they get that much of a nutrition from this part. This surgery was first devised in 1960. So you can imagine how many years. And today we perform the most advanced and sophisticated Roux-en-Y gastric bypasses. Here I would like to mention about diabetes. How it treats the diabetes majorly is the food that comes here remains here for 2-3 hours, the raw food, whatever dal, chawal, sabji, roti that has come here, then it remains here, made into a paste form and then goes here for absorption. It goes and get maximally absorbed, and then it would enter this part of the intestine. Now by doing Roux-en-Y gastric bypass, now the food has come here, the raw food, it is from here, it has entered this part. About say patient going for this Roux-en-Y gastric bypass, say 30-40 years of age. Now this raw food that enters this part of the intestine, the internal lining, we call it as L cells. Those L cells in this intestine, because of this raw food, they secrete GLP-1, and that is the hormone that works on pancreas, and that hormone reduces your glucagon from the liver while increases the insulin secretion from the liver. So this is what is important. The cost of obesity is all because of the complications after obesity, which turns into diabetes, nephropathy, heart diseases, and all. Now, these surgeries, because these are metabolic surgeries, these are not for cosmetic purpose. So, these days, since 2020, October 2020 to be precise, we have started getting into insurance. So, all these surgeries, they are covered with your valid insurance. Thank you very much.
Thank you, Dr. Sanjay, for such an eye-opening session and discussion on adult obesity. So the third speaker for today, Dr. Rahul Borude, he has done his fellowship in hepatopancreatic biliary surgery at Jaslok Hospital and is currently practicing as bariatric surgeon at Raheja Hospital. Dr. Rahul's presentation today will focus on the incredibly fresh and captivating topic, childhood obesity. I request Dr. Rahul to address the audience.
Good evening, everyone. My name is Dr. Rahul Borude. I'm a bariatric surgeon from Mumbai and India. Thank you for joining us physically and virtually here. I would like to thank Mayor for granting me the opportunity to speak on my favorite topic, which is obesity and specifically in children. So, post Dr. Sanjay and Dr. Mr. Rohit's presentation, we've all been sort of well informed about the prevalence of obesity in the adult population. However, I'm going to be speaking primarily more on the adolescent subgroup. As you can see on the screen, the World Obesity Atlas differentiating between from the 1975 to 2016 in the boys and the girl subgroup. As you can see, the blue are in the lower sector as well as the red being in the higher sector. Just to give you a stat, there are 340 million children all over the world globally were considered obese, not even overweight, obese, from the age of 2 to 19 years old. America and Australia being the highest numbers globally. Locally in the Indian subcontinent, as you can see in the World Obesity Atlas, as recent as 2022, the adult population showed around 11% of obesity, which was a high increase annually, which was from 5.2, but more alarmingly in the adolescent subgroup showing 9.1, which is very high. Now, these numbers may be small in comparison to the world, universally and globally, but however, in Indian subpopulation, as you know, these numbers are very large. The National Health Survey also of 2016 to 2019, which stated 2.1% of obesity in the adolescent subgroup, showed a significant rise going up to 3.4 in 2019 to 2021. Which again, like I said, these numbers sort of compound, stating that 1 in 10 children globally by 2030 will be from India and overweight, not just obese, overweight. So, what are the causes primarily in these subgroups, adolescents? Is primarily owing to the lifestyle changes, which is organic food, more cell phone, more screen time, and less of outdoor activities, suggesting more sedentary lifestyle. So what are we doing to treat childhood obesity? Now, diet, exercise, and medical therapy have been accepted globally and more or less in India as well. We have tried the same sort of treatment in the adult group as well. Diet, as Dr. Sanjay and many others have suggested, input less and output more. You have to have a well-balanced diet with having more protein and less of processed carbohydrates. Physical exercise also is one of the biggest armamentarium, one of the line of treatment. Like I said, burning more calories than putting it in. Thirdly, as we have been informed, orlistat is a medical line of therapy in the adolescent subgroup, which also has shown variable results, but however, the compliance is poor. So we all know these line of treatments are sort of taken care and given and considered as a primary line of treatment for adolescent subgroup. However, what are the results shown? This is similarly also shown by the pediatric board as well, suggesting some marker. Yeah, some marker. Oh, sorry. Yeah. The pediatric journal as well suggesting the management being cognitive and a behavioral therapy, such as suggesting regular meals, which is breakfast, 45 minutes of exercise. Similarly, other cognitive and behavioral therapy. In the medical line, they have suggested metformin and orlistat as a treatment for individuals with high BMI or overweight. Whereas the surgical part is sort of overlooked and sort of has been considered as discouraged and indicating more significant complications in the adolescent group than the adults. However, the opinion worldwide is different. The guidelines suggested by the American Association of Pediatrics recommends metabolic surgery as a treatment of choice for children with grade 2 or grade 3 obesity. European Association of Endoscopy and Surgical Metabolic Surgery also have sort of changed their opinions, where their surgery is considered with individuals with BMI of 40 kilograms and BMI with 30 or 35 with comorbidities. So why are we still knowing the fact that the population that we are, the numbers that we still are not looking up surgery as a line of treatment in treating obesity? As you are aware, as stated by Dr. Sanjay Borude, that the ASM-based guidelines for BMI for bariatric surgeries have been revised. They have been more sort of Asian population centered, reducing the BMI category to 30 and 25. So do we need a similar novel approach in treating adolescent obesity in the Indian subpopulation? The West, as we generally are sort of leading the way and we tend to sort of mimic or copy their line of work, should we also sort of adapt looking at the setting here? So what are the parameters for consideration for a change or a novel approach in these? Just to simplify, I've sort of categorized them into three. Age being the first one, the severity of obesity and complications, and the third, I think, which is the most underspoken, is the psychosocial burden. Let's address the age part. Now, we all in our Indian society, we've all seen the complex sort of disease in our Indian subcontinent. At one end, we are facing malnutrition. We've all seen kids with low birth weights. We've all sort of told them to eat more. We've all instructed mothers to feed their babies. However, we still now are facing a similar sort of issue in the metropolitan specifically, where there is increased amount of adolescent or pediatric obesity. So the common perception that the Indian societal is that a healthy baby, a chubby baby is a healthy baby. Yes, that is most of the period time. Right. However, these things need to be altered and updated. As you can see in the Indian setting, we'll all see a parent or a doctor as well to a certain extent saying that if the child is obese maybe in the pre-teens or around the puberty, they will tend to lose that weight during the puberty. We'll say, okay, the kid will lose all of that weight. However, is that the same case with what stats says? So annoyingly, that is the opposite. Around 55% of obese children go on to be obese in the adolescence. Around 80% of these obese adolescents will be obese in the adulthood, and around 70% will be obese over age of 30. This is the same study that was conducted in the US as well. The second query that I would raise is the complications. So are we benefiting by delaying any form of surgical or medical intervention by the severity index of the comorbidities? Do all of these comorbidities take a backseat or worsen over a period of time? Studies such as these suggest otherwise. Early intervention, these studies which was conducted in the last decade have suggested an early intervention, be it medical or a surgical, have led to a better remission or treatment of comorbidities in the adolescent subgroup. The same results and stats have we seen in the adult population, however, they were more promising in the adolescent. Whereas small, as severe as kidney function, type 2 diabetes and OSA have complete better remission rate than any other. So obesity in adolescent females also is a big consideration. We've all seen individuals, specifically in the teenage brackets in the metropolitan cities, are suffering from early diagnosis of infertility with an underlying cause of PCO. So are we delaying with any form of intervention this disease, or is there a possibility of treating this in a better way? And the third and the final, I feel, which is the underspoken and the undertreated one, is the psychosocial burden. We've all discussed mental health. We've all sort of are treating, and we've all sort of seen an individual in all our social medias and movies, books, everywhere, that we've all ridiculed, we've all joked about a fat kid, right? And we find it humorous, which is yes. But however, the consequences that the child goes through in the formative years, specifically I'm talking about pre-teens, which is under 13, these are developmental age where a child sort of forms his identity. With an individual, the child suffering from obesity and burdened with excess weight, that leads to many psychosocial consequences such as social isolation, victimization, anxiety, depression, which eventually burdens them and leads to developmental stunt. We've all known that this have been proven that this stunts brain growth over a period of years, and these consequences in the teenage years or in the adolescent group leave a big mark in the adult lifestyle. We've all seen a child who is obese as a growing child will always tend to be obese, and they will carry forward all of those lifestyle issues in their adult life as well. So what are we doing for this? So because lack of evidence from the last decade, we never sort of considered bariatric surgery or any form of restrictive surgery in the adolescent group. But that has changed in the last decade. There are many studies conducted over the world, specifically the Ghazi one, which is in the last long-term results for bariatric surgery, which have shown promising results in remission and treating obesity in toto. We also have a similar case study that is we have conducted in the last decade, two specifically being Master Ibrahim here and Zoya Khan, which Dr. Sanjay Borude stated earlier. The 11-month-old baby, she's currently 11 years old and thriving. She's reached all her developmental milestones, and we hope the same for Master Ibrahim as well. The other benefits for an early intervention through a surgical and a medical intervention is the psychosocial part as well, where children tend to increase in their self-study, improve post-surgery. Anxiety and all other mental health issues have been addressed and treated in a more optimal way. So similarly, what the take-home message is, to treat obesity in a child, there are multimodal factors for it to be diagnosed and treat. Similarly, the treatment also should be holistic and multimodal as well. So along with a cognitive behavioral therapy, I would believe that an early intervention of medical or a surgical in particular cases is required for an optimal result. Thank you.
Thank you, Dr. Rahul, for enlightening us with such a new perspective and solutions to combat adolescent obesity. Next up, let me invite the chairperson of today's event, Dr. Nitin Patankar, consultant in diabetes, obesity, and metabolic medicine. Dr. Nitin has several publications on obesity, nutrition, and endocrinology. His work has been published in several newspaper articles, and he is an author of Marathi book on obesity management. Dr. Nitin has special expertise in yoga and music therapy. Dr. Nitin trusts Reshape as the first-line therapy for obesity management. I invite Dr. Nitin to share with us a few thoughts on the united efforts we can put together to combat the vicious cycle of obesity at all stages through our Q&A round. I also wish to invite Dr. Sanjay and Dr. Rahul and turn the session into an open forum and request the estimated audience to direct their clinical queries and experiences to the faculty. Please address the stage.
If there is any rebound obesity after the surgery, and if so, can we use any anti-obesity drugs for treatment of that?
It's a very important and a very common question that has come to us. See, go anywhere in the medical field for the treatment, there is always someday there would be a bounce. You go to my colleague here sitting as cardiothoracic surgeon. So any person that goes for certain specialty and the doctor lays down all the do's and don'ts, patient has to follow them. Similarly, here in obesity surgery, post-bariatric surgery, what does bariatric surgery actually do to that particular patient? Suppose the patient has to come to near normal body weight, that is say 50 kilograms the person has to lose in a morbidly obese person. By bariatric surgery, we make it simple and give it to him. So all this patient, they lose about 40 to 45 to 50 kilos of those weight. But the maintenance is always with the patient. So we lay down all the do's and don'ts post bariatric surgery, and patient has to follow them strictly. Follow programs are the crux of the treatment post bariatric surgery. We lay down about every 3 monthly follow-up for first 2 years, and then at least once in a year follow-up until 5 years. Patient, those who have successful in maintenance of the lost weight for first 5 years post bariatric surgery, they can easily maintain that lost weight for next 20 years.
Yeah, the original question was whether there can be a regain of weight after bariatric surgery and whether you can use their brand Reshape. So definitely, as Sanjay said, that you take any treatment and if the do's and don'ts are not followed, there is bound to be a relapse of that disease, whether it is diabetes, heart disease or obesity or anything. So, and practically we have seen that whatever do's and don'ts we give, people are going to follow it 50%, very few are going to follow 100%. So there is always a chance of some regain of weight, and if the person wishes that his efforts should be like supplemented by something, then we can give a pharmacological treatment or even after bariatric surgery. So we get patients like this, and this, when they are eating some kind of a fat in their diet and they have got a tendency to put on weight, Reshape definitely works.
One more point I would like to mention here is, like today we see cancer surgeries. We have the medical oncotherapy as well as oncosurgery. So normally it goes hand in hand. Similarly, now the world is changing, the science is evolving now, and it has evolved also. So post bariatric surgery, now we have also started off, looking at the medical pharmaceutical management along with in that post-operative period. So it's a combination of therapy, surgical as well as pharmacotherapy also.
So I always remember that whenever the politicians come on the stage, they always mention कि आम्ही प्रतिस्पर्धी आहोत, आम्ही शत्रू नाही. So many times it is perceived that bariatric surgery versus bariatric medicine, they are opposing one another. In fact, they are complementary to one another. Yes. So even before bariatric surgery for 6 to 8 weeks, if you give medical treatment, the liver shrinking occurs, the patient is more fit for surgery, and then the surgery, and then again take over by medical treatment. So that is how the things really go, but there is a general perception among public that these two don't go hand in hand. So that is not true.
So do we have any questions from the audience? Yes, sir.
Usually after the lifestyle changes, patient is not able to lose weight. Then probably we put them on Orlistat. Now after 1 year of Orlistat, patient is on say 99 kg to begin with. And at the end of 1 year is again 99. What would you do?
The question is for me? Yeah, would you like to answer?
See, basically there are, like any other drug, there are responders and non-responders. Similarly, there is a phenomenon of tachyphylaxis kind of a thing that occurs with any drug. So even with Orlistat that happens. And if the person has followed diligently, like he said in his lecture that with optimum medical treatment, if the patient is not losing weight, we have to put forth to that maintaining 99 kg will carry a definitive risk. Against that, whether you want to undergo a surgery and then you want to lose weight, come back to even we assume he is 30 kg overweight. So at least 15 to 20 kg loss can occur with bariatric surgery, and whether you want to live a healthy life. Second option that we can give is like the newer drugs that are coming. They are combos of diabetic medicine and obesity medicines together. So that can be offered. But in today's scenario, those medicines are costly. So I have seen patients saying that if I want to take this drug for 3 years, I will go for a surgery because surgery will be cheaper. No, if on Orlistat, if 1 year is a sufficient time, within 3 months, we usually see that you have to lose in first 6 months, at least 3 kg a month. If he is not losing, that means not responding. So I don't know what you are saying, that from 99 he came to 70 and then again came to 99, or he just maintained 99. So even you don't have to wait for 1 year. You have to give a choice within 6 months. That's what I feel.
In bariatric surgery, like when we started off these surgeries of 23 years ago, and now after 23 years, now we have become very wise to understand the complications or weight regain problems in bariatric surgery also. Weight regain can happen, and it is at the tune of about 15 to 18% of our patients. They come up with one particular step 1 surgery, that is sleeve gastrectomy. We have been seeing this weight regain problem, and it is primarily not because of the surgical method which is offered to that particular patient, but it is purely the patients learn to cheat the bariatric surgery over a period of time. So like again, when I go back to some certain different, the surgical aspects, one is again cardiothoracic surgery, joint replacement surgeries, onco surgeries. They all have some life, about 10, 12 to 15 years of life. Every surgery has. This is what now I'm started changing my perception towards surgical treatment to any facet. Most of the patients after 10 to 15 years of successful interval, they come back with some of the other problems, but we have another armamentarium in this tool here is revision surgery. The revision surgeries can be done safely as per the primary surgery. So today we are definitely doing revision surgeries, which gives them another 10-15 years of good quality life.
And I would like to add to what Sanjay said, that in diabetes we say that in first 5 years you have excellent control, and then I've got a modest control over next 20 years. Still at the end of 25 years, we have much lesser complications than who doesn't have a good control on first 5 years. So we call it a legacy effect. Similarly, in obesity, we have seen that if the person remains obese, when he have gained certain, say, BMI beyond 32, then he is constantly attacked on his organs, starting from joint to endothelium. So if you treat early, and then even if the patient starts regaining weight, he is gaining that, as he has seen, 10 to 15 years of more healthy life. So he is getting that legacy of health. So positioning a treatment and applying it at right time is more important.
Yes, moving on to the next question, I would like to ask Dr. Rahul. So, childhood obesity, what risk does it poses in the puberty or during the adulthood? And what can be the preventive measures for it?
Similarly, I'll have the same answer. Something similar. Obesity is a lifestyle disease unless proven otherwise. Now, otherwise, as he mentioned, if there's hormonal or a genetic mutation in that. But eventually, it's the lifestyle that needs to be corrected. A child, when it grows, the growing up, what environment it grows up is very essential. That includes your home, that includes your social, and that includes your school, which is in the adolescent subgroup. What we sort of target is to eliminate the obesogenic environment. Now, a child is never obese alone. If a child has poor eating habits or their relationship with the food is poor, most likely the parents also share the same relationship with the food as well. Their dietary patterns are also poor. So when dealing with a child, you have to treat all three factors. How does a child relates or sort of work during in their social setting, and similarly in the school setting as well. What the child eats in the school canteen, what the child is fed in the tiffin. So these things have to be addressed in toto while you're treating adolescent obesity. The problems are similar, like I said, a small mistake, something as an error during these formative years leave a mark in the adult lifehold. Something as simple as emotional dependency in food. We've all seen children being fed cake or fast food such as McDonald's or anything which is what high calorie sweetened drinks during birthdays, or for the matter if you see a child is sort of emotionally sort of turmoil or anything, we feed them, okay, go have a chocolate. Chocolates are great, yeah, fun, I would never sort of hold back a child from eating a chocolate, but however, the child, whenever they're depressed or sort of relates to a low self-esteem, they end up moving to these these food groups because they find emotional dependency on it. So creating a good calorie literacy is very important when you're treating childhood obesity. A child today does not know what they're eating. I mean, we've all not known what they're eating. I mean, I never knew what the word calorie existed until I came when I was 15 or 16 years old. If you ask the same, I'm assuming the same situation you see now as well. So calorie literacy is very important. Teaching the child what they're eating is very important. I know it sounds tedious, but eventually I think that perception changes. I've conducted the same study with my patients as well, where we've introduced the children into the kitchen. Now, child only goes to the kitchen just to meet the mother or grab a quick snack, which is easy to find. But when you sort of introduce a child into the kitchen with a different perspective, what are the nutrients in a broccoli? What are the nutrients in a cake? You don't have to sort of model it. You just have to explain what calories are. And I think that plays a big role eventually.
I would like to add one little on lighter note. What he mentioned is we have created a obesogenic environment and child doesn't become obese alone. So there was a lot of debate was going on whether nature versus nurture. So what can cause obesity? And these questions were definitely answered not by a doctor or a surgeon or a physician, but by a vet. So he had 7 or 8 generations records of puppies. And usually when puppies are born, they are not kept. All the puppies are, because the litter is 4 or 5. So they are gifted or sold. So he had kept all the records, and he found out that at the end of 7 generation, all the studies, the puppies which were given to fat families became fat. And puppies which were kept in the thin families remained thin. So if the puppies can have that much influence of the family, I think a child also has got a similar
Rightfully
influence.
said, sir. Rightfully.
My question is to Dr. Patankar. Doctor, in which all cases you will recommend reshape natural?
Yeah. So the first of all, if I find that the patient's metabolic rate is low, and how can you find that out? That if the patient is doing good amount of exercises, patient is following a moderately restrictive diet, and third thing is his fat tissue, we call it, though we don't do histopathologically, if we assume that he has got more of a white fat tissue, then, and he cannot tolerate, say, reshape, that orlistat, because he starts getting of abdominal complaints or something. So these are the 3-4 parameters we have to judge subjectively, and that is the point when we recommend reshape natural, because it has got, as Rohit has mentioned, that it has got a totally different outlook towards treatment. So it basically Garcinia cambogia or other methods which have got 2-3 things, that burning fat, preventing carbohydrates from getting into fat, and converting something like a beach fat tissue, that is from white to little bit of browning of fat tissue occurs. So if I want that to happen, then I will choose reshape natural as my treatment.
Thank you, doctor. And next question is to Dr. Sanjay. Doctor, can you elaborate on epigenetic of obesity?
Epigenic, I think Mr. Rohit has elaborately said again, but patients who are born with genetic problems, that we have also seen about 52 patients we have tackled so far as child obesity, and with they always had that varied problems in the genetic. So epigenetic treatment with this, which is more based on your lifestyle changes, but lifestyle changes in children and adolescents obesity, which is not practical. I cannot stop a child from a tasty, which is a junk food. Children will always, flock towards taking junk food. Again, the families, especially in India, they would not allow all the birthdays, all the what food, the food which is offered to children is all high dense calorie food. So epigenic approach towards child obesity is a bit difficult to me.
Our Indian food lacks on protein. We are supposed to have about 1 gram per kg body weight per day. So protein intake, and second thing is in children I find that now they are not exercising, so they don't have enough of muscle mass. And same in adults, after the age of 30-35 we have a sarcomere loss. So protein intake and weight training in both in children and in adults.
Yeah, definitely. I've always felt that even though we, as an Indian diet is complete, but I don't think is right for us. We have 2 sources of carbohydrates in our plate, which I feel should be more of protein and less of carbohydrates. Protein can be in form of meat or in vegetable form as well. So I circle back to the same point, is the calorie literacy. If you have to make a child just be aware of what they're eating and what they're putting in their body. Like he said, it's very tough to sort of hold back a child from high sweetened or anything that is junk. But making sure the child is eating right, and leading by an example also. So I would say the parents, if they have poor dietary habits, it's a very tough sell for a child to make them eat the right kind of food. So again, same thing goes for your lifestyle choices as well. If a parent does not work out regularly or exercise, it's a tough sell for the child to also, because a child generally just observe consciously and subconsciously. So you have to lead by an example. So it does play a big role in your puberty and your formative years.
I would like to add one thing, that what you mentioned is correct, that we have to have around, as adolescents, we have to have at least 1 gram per kilogram body weight of proteins. And poorly, unfortunately, we have around 0.6 grams per kilogram body weight of proteins in the diet. And carbohydrate source is never known. We think that cereals are carbohydrates. But even the pulses, that vegetarians, they think that if I substitute cereals with pulses, I am getting more proteins. But look at that, rice is 7% protein and 93% carbs. While if we switch to dals, it is like 14% protein, but 86% is still carb. And obesity originates, or diabetes originates, from not handling carbohydrates properly. So as we are going into advanced technology in food, now we ask them that you reduce your carbohydrate content, replaced by proteins. So if the person is not meat eating, so, and even chicken, if you have 100 grams of chicken, it's just 35% protein, not 100%. So, but today the technology is advanced, food technology is advanced. We have got pure vegetarian proteins in various forms, like chickpea protein, rice pea protein. Then there are various other kinds of cereals which we extract proteins from, like mung bean proteins. So in our Hiranandani Hospital and Jupiter, where I practice, we advise them to include these proteins into their diets. So mix your attas with these proteins so that your protein component is maintained, which increases your metabolic rate, which maintains or prevents sarcopenia from developing. So nowadays, if the junk food is going to be around us, we have to be cautious that we reduce the carbohydrate content by manipulating the diet. And luckily, we can now maintain the taste and still make the foods look like junk.
My question to Dr. Nitin again. So, Orlistat 60 mg or Reshape 60, we have found that scientific evidences that it can be used in adolescent obesity, that is in 12 plus age group. So, what is your take on the same? Like, how can Orlistat work in adolescent obesity?
I think that should be to Dr. Rahul. And whether, first of all, I think Orlistat is now recommended and allowed for beyond 12 years of age. So, and these kids are going to eat fat. If there is more fat in their diet, Orlistat is going to form those micelles and there may be a leak, or they may pass oil. So what I usually recommend when a child is referred and when they don't want to go to meet the surgeon in the first place, I recommend to eat some form of a fiber, basically any form of a husk, insoluble fiber. And mixed with that, if you give Orlistat, these fibers, as we know that fibers form a mesh and bind fat. So even if it goes to the lower intestines, the fat that is not absorbed is also bound, so that the leak is prevented. So the child won't feel embarrassed when he goes out somewhere and with flatters or when passing stools or involuntarily, the chances of passing the oil, and which is the most embarrassing thing. And that's why Orlistat is not usually used, because even the physicians are scared of if this side effect comes, then the image of a physician is hampered. So they refrain from using Orlistat. But for children definitely, or for adults also, I recommend fiber with Orlistat. That is the better thing. Rahul?
Yes, I would completely agree with that. I've always shared the same opinion. Orlistat is a great supplementary line of treatment along with lifestyle diseases, lifestyle modification. So a child who's obese, suffering from obesity, the introduction of a medical line of therapy in the line of Orlistat is always beneficial, but the end goal is to sort of have the child off all medications. We don't want to replace one medication with another. So again, like Sir said, the compliance and everything has to be sort of well informed and sort of treated well holistically.
Right. So next question is for Dr. Nitin. Can a person take anti-obesity drugs for weight management after his bariatric surgery?
We initially answered that when we were talking about weight regain after bariatric surgery or post-bariatric surgery management. And Dr. Sanjay has already mentioned that the follow-up is for 5 years. So in that time, if the patient starts even gaining weight and we want to maintain weight, Orlistat is easily given, and that is given. I think Orlistat is prescribed more by surgeons than by physicians, because physicians are scared, and person has undergone a surgery, then he will more likely to follow the medical advice and the lifestyle modifications after surgery, right?
Yep.
Yes, any last question we have from the audience?
Dr. Rahul, can you elaborate on what is hunger and hidden hunger?
So it all circles back to the psychological part as well. Hunger and hidden hunger, it is, as Mr. Rohit established before, it plays along with your body. You have to understand what body is, what your body is craving, and what your body requires. There are two different parts of it. We all are hungry because we tend to lead a lifestyle, and we tend to stick to a routine which we sort of respond to our body responses. However, the external stimuli, such as something as emotional or resistance, that is sort of needs to be addressed. So hidden hunger is something that is, I feel, undertreated, or for the matter, the right line of treatment is not done. But I would say you have to sort of treat the underlying cause of what the problem is with the child, in regards of your hunger. Is it a body requirement or is just this external stimuli? That's what it is. There is nothing better than that. So metformin and Orlistat are the two only line of drugs that are sort of administered by and approved by the Pediatric Society. However, there's nothing else in this. So, like I said, the crux of line of treatment is behavioral, cognitive and behavioral therapy. The rest is all supplementary, even surgical, medical, everything as well.
Yeah, the surgical as well as medical line of treatment, when you consider children as unless they are morbidly obese, we don't, start any kind of neither pharmacology nor surgical. Even we are the surgeons, but we don't recommend surgery at first go. Unless the child has life-threatening issues, then only we advise them pharmacotherapy or primarily what I personally feel is training the parents or training the society at large is most important to control children obesity.
Good evening. I'm Dr. Subeda Tumbi. I'm a clinical nutritionist practicing in Andheri. When we talk about using Orlistat, we are also concerned about the absorption of fat-soluble vitamins, vitamin A, D, E, and K. Because when you have leakages and the child is growing, and we are well aware that vitamin A, D, E, and K are required for growth. That was one concern. The other concern was using fiber with your meals to kind of, stop the leakage, as you were saying, Doctor. So when we are looking at extra fiber with the meals, are we not also looking at interference with iron absorption? And the child is growing, so the child who is not allowed to eat much, and if the parents are not really, educated or mentored to make balanced meals, which talk about enhancing iron absorption or looking at vitamin A, D, E, and K, the sources. I mean, as it is, our population is not so well educated or they're not very well guided. So the concern is, what is the impact on the growth potential?
So it's a very good question, and I thought that somebody should ask that, because when we prescribe Reshape, it's usually a concomitant prescription of vitamin A, D, E, K is given. It's known that Reshape doesn't cause any like excess loss of these vitamins or vitamin deficiencies created by Reshape, because Reshape acts just at the initial part of the duodenum and jejunum. So, but the absorption can take place later on. And the fat-soluble vitamins are not absorbed if there is no fat in food. And that's why the fat has to be there and it is absorbed. So it's not that 100% fat is blocked. Some fat is blocked. That is one thing. Secondly, when we are giving fiber with that, apart from or away from meal, we usually give at least 10 days a month the iron supplements. Iron, vitamin C and vitamin A is already going on for that patient. So if you look at the total medical management, the Reshape or the Orlistat is just a one pointer. And that's why people feel that the prescription is so long. So most of the prescriptions is a concomitant prescriptions, the main drug. And that's why when I write prescription, I say, okay, these are the essential drugs for your treatment. But it is better that if you take the following medicines, though people want that something should come from natural foods. But as you know that even today, vitamin C, in 30 years back, orange was giving you around 500 milligrams of vitamin C. Today it gives just 35. So because of genetic dilution. So I don't believe in supplying everything from natural foods, because then the package deal is giving a lot of carbohydrates with that. So on one side, I want to restrict calories. So there is no shame in writing supplements when you are treating obesity. And as Rahul said, that as quickly as possible, you shift them without drugs. And that is what we call it a modified foods, which can be taken for a longer time.
Question.
So this is an online question, as we have 14,000 people watching us online right now. Rajiv Khare has asked you what amount of weight loss you would advise per month. This question is open to all.
Open. In the adolescent subgroup, or is it in the adult population? Okay. So I would begin with 3 kilograms per month for an adolescent subgroup. However, I'm not fixated on that number because, like we said, weight is formed of 4 major things: bones, muscles, fat, and water. My ultimate goal is to increase the muscle mass and reduce the fat percentile. So I take the weight with a pinch of salt, but however, I keep a look on the body composition more importantly. So I would like the muscle mass to increase. So as the muscle mass increases, your weight also increases. So I'm not too stressed about the weight, but my target would be 3 in the initial phase, 3 kilograms per month.
In particularly for the adult obesity, if we are considering for this to answer this particular question, it all depends upon how much is the excess body weight, and the weight loss that happens according to the excess body weight. Higher the excess body weight, higher the weight loss that starts after the bariatric surgery in adult population. That goes at the tune of about 14 to 15 kilos per month, and which slowly tapers down to no weight loss over a period of time. So it's variable.
So I would answer that question in a little different way, that we are looking at initially, as Dr. Sanjay said, that initially the overweight state is 30 kg. Then I would like the person to lose around 4 to 5 kg for first month. But ultimately at the end of 6 months, the average comes to 2 kg a month, 2 to 3 kg a month, as Rahul said. But more importantly, we have to look at fat loss. So whatever weight loss is occurring, 30% at least should be fat loss. And why I'm saying 30% is because if you assume that the person is losing carbohydrates and fat in equal proportion, because if respiratory quotient is remaining around 0.8, then every gram of carbohydrate that is stored with 3.5 grams of water. So if you lose 1 gram of fat, 1 gram of carbohydrate and 3.5 grams of water, it's 5.5 grams of loss. We'll have only 1 kg or 1 gram of fat loss. So whatever is losing, initially if he's losing more carbohydrates, more water loss is there, then that's why there is a more weight loss. So initially that's why even 5 kg weight loss, I would look at that at least 1 kg of fat loss has occurred in that month. And as the days progress, the patient is losing 2 kg a month, it can be around 1.8 kg fat loss is occurring. So I would answer that question that more focus is on how much fat he is losing rather than how much weight he is losing.
So on behalf of Mayor Vita Biotics, we thank all the estimated guests and our guests of honor, Dr. Sanjay, Dr. Rahul and Dr. Nitin, for gracing our event and enlightening the audience with their vast clinical expertise. We have together made this event a grand success and have developed a commitment to touch millions of lives by spreading the awareness of breaking the obesity cycle. Let us understand the value of this integrated approach and encourage individuals to explore the benefit of early stat as a part of weight loss journey. Thank you so much, doctors. Thank you so much.
Thank you very much.
Doctors, please be on the stage. I would invite Ms. Suma and Mr. Rajesh to please felicitate our guests of honors.
So on behalf of Mayor, I would like to thank Dr. Sanjay Borude and Patankar and Rahul. So it was very enlightening, and we at Mayor, being always committed for the health and wellness, we are very happy to get associated with this awareness. At the same time, the treatment options, those are available, and we'd like to thank all the doctors, offline as well as online, who could come and spend their precious time here. Thank you very much.